All right, chapter 16. Nursing management during the postpartum period. Y'all need to know how to take care of the client after they deliver. Some of the information is going to be redundant from chapter 15. It's all good. This is where parenting is going to begin. This is where hopefully a bond between the birthing parent and the child take place. And this is also the time where family starts to make adjustment in their new roles and their routines with relationship to this new human being within the picture. Okay? Now, it is important for you as a healthcare provider to remember that parenting is a skill. No one knows this skill naturally. No one was born knowing how to parent. So we learn as we go. Okay? You might get it right with the first baby, hopefully, or you may not get it right until the next babies. Gotta be careful with that one, okay? The next babies, okay? But parents must learn new skills, and the baby must be integrated some way, somehow into the family life, okay? Now, there are physical changes that does take place, as you already know. We already know that the birthing parent's body is starting to slowly return to normal, as we discussed earlier. It does take several weeks, okay, and those changes could be significant. As nurses, you got to remember, we have to recognize what is normal versus what's abnormal. But especially, not only, because of when you have to take care of this person, individual, but for testing purposes as well. You need to know what's expected versus what's not expected, because the unexpected becomes your priority. Remember that the unexpected becomes your priority, especially for testing purposes. So identifying those problems early on, prioritizing your care accordingly becomes very important, and you need to know or be able to monitor those the changes both physically and also emotionally as well. When it comes to taking care of both the birthing parent and the new child, the nursing care involves assessing for physical recovery, monitoring for emotional adjustment, just like how we talked about earlier, like postpartum depression, etc. Supporting the bonding and attachment between the birthing parent and, again, also with the partner involved, and evaluating how the family is adapting. Is there any adaptation taking place in the first place? Remember, safety is a priority as well. So if they're not adapting well or adjusting well to this new baby, we have to investigate further for any potential harm. We're also making sure we're assessing for comfort. All right. We're also assessing nutrition. Are we eating properly? Are we properly hydrated, etc.? Self-care, very important. How is the mom taking care of themselves? Are they even taking care of themselves, or the birthing or the partner involved as well? Are they taking care of themselves? And then, of course, we talked about contraceptive needs. Remember, the myth is about breastfeeding will protect me against future pregnancy. You got to educate accordingly if that's the thought process. The hospital stay, we hope that it's a short hospital stay, but hospital stays are typically shorter these days than before back in the day, because nurses focus on priority needs, follow-up care, and ongoing support. This is why you notice these days hospital stay postpartum, if there's no issues, it's usually shorter. Okay, so again, we're looking for emotional and physical well-being, learning new parenting skills, and strengthening the bond between baby and the parent involved. So on page 487 and also on page 488, the postpartum period. What are the assessments or data that we're going to be collecting? We must, as nurses, carefully assess the birthing parent, of course, the newborn, and the family. The goal here is just basically to promote a healthy adjustment, like we said earlier, detect any complications and reduce any discomfort, and provide education and support as possible, okay, whenever it's necessary. You got to know that assessment, pay attention to this. Assessment begins within 1 hour after birth. Assessment begins within 1 hour after birth. When does it stop? Does it ever stop? Steph, yes or no? Does assessment ever stop? No? No, why not?
If assessment ever stops?
Yes.
I don't think so.
Why not?
We should always be assessing.
You should always be assessing. Okay, so you're gonna be with that mom for the next 24 years.
Well, while they're your
Okay, so the assessment does stop at some point. Make that hopefully I look at this point and make sure this is a test question. I'm gonna try to make assessment never stops, okay? Lorianne, when does assessment stop?
Before discharge.
Before discharge? You should know this is fundamentals. Y'all know patients ain't with y'all forever, right? Y'all don't know this. It doesn't matter the setting. Until when you leave, we got y'all. What are you assessing when a patient leaves? Hello. What are you assessing when the patient leaves you?
The survey.
The survey. Age caps. Okay. So assessment starts 1 hour after birth up until when?
discharge.
Yeah, guys, that should be like an easy peasy response. Okay. All right. Again, like I said, make sure you know what's normal, and make sure you know how to detect serious complications. And early detection helps prevent serious complications. I'm trying to say, all right. So assessments are done for the first hour. I have up here every 15 minutes. For the first hour postpartum, you are assessing this child. The child too, but the mom. Okay? Don't play with me, Zelda. Okay? How often for the first hour?
Every 15 minutes.
Don't play with me. Okay? You see, I put it right and very nicely right here for you guys, so you don't play with me. And then the second hour, you're assessing every 30 minutes, given if there's no issues or complications. Okay? Then after that, within the first 24 hours, your assessment is every 4 hours. Again, if there's no complications, no issues. All right? What are we assessing? Vital signs. We already talked about that. We want to make sure we gather certain data such as their medical history, any past medical history, pertinent past medical history. We may not be interested in knowing that you had a tonsillectomy when you was 5 years of age, for example. Okay, that's probably not important right now, but pertinent. Like if you had, for example, are you taking certain medications, for example, like seizure medications, we want to know this because those have to be tapered out. Now you are at high risk. So those things, for example, if that is an issue. We are assessing also for pregnancy and labor complications. We already talked about those. And we want to make sure we know any treatments that they receive during labor, delivery, and of course during the postpartum period. We are watching and monitoring for danger signs. So again, we talked about some of them. Signs of infection. Zelda! What are some signs of infection?
Fever.
Oh! Don't say anything. Your patient has a temperature. She is 12 hours postpartum. Temperature of 100 degrees, 0.1. And everything is otherwise okay. What are you doing with that? Now be quiet, damn it! If you so much as to even whisper, I'm coming after you.
100.1.
100.1, 12 hours postpartum. Every other assessment is fine. Just the temperature is 100.1. What do you do with that?
Isn't that normal?
I don't know, you asking me or you telling me? You telling me? Okay, so you ain't answer my question. I asked you what you gonna do with that.
Probably look at her labs.
Okay, you gonna probably look at her. Okay. Probably look at her lab. I like it. And what labs are you looking at? Do not say anything. Medicine, quiet.
White blood cells.
Give that girl stickers.
No, for real. Okay, wait. You looking at her white blood cell? Okay.
Oh shit. She gonna ask you your number.
Okay. Hold on. Cause you the great fantabulous L&D nurse. This was your dream job anyway. Okay? Temperature is 100.1. She's 12 hours post-op. You decide to look at the white count. White count is 19,000.
Probably called the
Why are we calling a provider? Huh? Because it's elevated? Serena, do you agree with your colleague's intervention?
No.
No.
Oh shit.
You disagree?
You have a hater in the house.
Serena, dígame. That's all I got. ¿Por qué you disagree?
Because it can go up to 20,000, or according to your size, 30,000.
So what would you do?
Monitor.
I'm gonna still give you a sticker though. Again, the white count is expected to go as high up to what again? 30. Now your book says what again?
20.
20. Alright, I'm gonna give something ridiculous if I want you to do some intervention. Alright? Are we cool? Temperature is expected to go as high up to what during the initial postpartum?
100.4.
100.4. If there's no other complications, we just continue to monitor. Yes, Zelda.
For how long?
Oh, for how long? Madison, are you laughing? You laughing at me? What did I do? How long? Because I don't remember.
First 24 hours.
What? Wait, the white count is expected to last. Okay.
Change her question in the middle of the question.
Okay. But the white count can stay as high, that high for how long?
4 to 8.
Okay. All right. So we'll just say a week, give or take. Okay. It's very important. You see timing? Pay attention to the timing in these questions. And y'all know I like my little one-page questions. Yeah. Don't play with me. Keep it moving.
You gotta learn to be a speed reader.
Yeah. All right. Just know what to look for. All right. So the danger signs again that you're looking for: signs of infection, heavy bleeding, abnormal vital signs. What else? Severe pain, emotional instability. Emotional instability is something else that you're looking out for too, because that's a safety issue, concern. All right. Now moving forward. Now you see here, vital signs. Let's talk about them because we already talked about them. Okay. You see? Did you see this slide already ahead of time, Zelda? No. Oh, okay. All right. Again, 100.4 within the first 24 hours. Usually it's because of dehydration. Just give them a little hydration, either the oral hydration or IV hydration, it should be fine. Temperature persistently above 100.4 according to your book. Again, other resources are saying something as high as 39. Okay? Now, I would try to put something way off if I expect the correct answer to be warranting of intervention of sorts, okay? But just know that for your book, for this class purpose, we'll say 38 is when you start, anything above 38 is when you want to intervene. But just know for NCLEX purposes, they might say something as normal as 30, even up to 39 may be considered normal. We cool? So hopefully they get something off. But it has to be persistent fever that will indicate, yes, there's a possible infection, and this is where you're going to look at other data that'll tell you that warrants further investigation. We got to do something about it. All right. Again, we're monitoring their blood pressure. If it's low, and again, specifically orthostatic hypotension, where they have, you may see dizziness upon standing, that's a problem. So there's a safety issue as well. Other symptoms that are danger signs is severe headaches, blurred vision, cough pain, shortness of breath. They might have a DVT or pulmonary embolism of sorts. We are not playing with this, okay? And again, remember we said not temperature, heart rate greater than 100. We said this earlier. This is when it is a problem. That's a danger sign, all right? Now, with regards to the heart rate, just know that according to your book, a drop as low as 40 to 60 beats per minute could indicate puerperal bradycardia, okay? Pulses over 100, again, tachycardia could be bleeding, infection, anxiety, pain, or other cardiac issues that warrant further investigation. Respirations normally should be between 12 to 20. Anything outside of this range, you gotta make sure you notify the physician, okay, and report it. Abnormal respirations could also indicate something as health issues such as pulmonary embolism. Maybe there's some pulmonary edema going on, or atelectasis, because remember there's a physiologic change that just took place postpartum wise. So you want to make sure, please. Do not be that nurse and use a stethoscope like this, okay? At the doorway and be like, oh, I hear crackles, okay? You better place that stethoscope next to where? Okay, it has to be touching.
The skin?
It can't be having, it was that simple. Yes, it was that simple, okay? Yeah, you should know the locations, okay? But also, they gotta be next, they can't be having layers of clothing too. And that's what you doing your assessment upon layers of clothing. That's a problem, okay? Lungs, you hope the lungs are clear. If not, that could be indicative again of something else going on. Blood pressure, we already said, it should return back to normal. If it stays elevated, it could be signs of eclampsia or preeclampsia, or something as much as what's the other? Gestational hypertension is the other one too. Okay, this can occur within 2 days, even up to 6 weeks after birth. This is why we still want for continuous follow-up. If the blood pressure stays higher than 140/90, that warrants further evaluation as well. We already talked about what low blood pressure can indicate. Make sure you familiarize yourself with that. Also, because of the low blood pressure, which could be a cause of epidural, so you want to make sure you watch for dizziness when standing. Always check the blood pressure at the same position each time when you're doing your blood pressure assessment. What else? Postpartum danger signs again. A temperature above 100.4, foul smelling lochia, like we mentioned earlier, heavy bleeding, like one of you mentioned earlier with a pad that is soaking in an hour. You should not be soaking your pad every hour on the hour. That's a problem as well. Large clots, severe headache or vision changes, cough pain, like was mentioned earlier, sudden weight gain. You should not be gaining weight after you have delivered your baby. You should definitely be losing weight because you just gonna at least lost 7 pounds or 6 pounds or however the baby weighs. You at least lost that. Plus maybe more because we're gonna talk about the amniotic fluid and some liquid, discharge and stuff like that. But if you are gaining weight postpartum, that's also a big issue. Okay? Rapid heart rate, like we talked about, the tachycardia, shortness of breath, pain with urination is also a problem. Couldn't it also mean that you're having an infection as well? And then again, severe mood changes or depression is also a problem. So we're going to make sure we assess, yes, with the pain. We're going to ask about the location, the type. Make sure you remember your pain assessment, your PQRST, not the heart rhythm, but all right. What would we like for their pain to be? What would you like your patient's pain to be?
0.
Hello. Wait. Yeah. Okay. At least the most, maybe a 1 or a 2. but especially after breastfeeding, okay? We don't want you to be in pain, alright? So again, we wanna make sure we provide comfort measures if they are in pain, which will include perineal care, repositioning sometimes also help, providing warm blankets, rest, fluids, giving analgesics like you mentioned earlier, like ibuprofen or what's the other one, Tylenol, if there's no contraindication. Make sure when you are giving medications, y'all remember what the contraindications are. Y'all mentioned NSAIDs. Alyssa, what's the contraindication to NSAIDs?
Liver issues.
What else? Liver? Well,
Nephrotoxicity.
Livers with,
Tylenol. That's what I thought.
NSAIDs or kidney issues and,
Stomach.
ulcers, like,
Stomach.
Say louder.
ulcers.
Okay, if you bleeding, you definitely not giving no ibuprofen. Okay? So make sure y'all pay attention to any potential contraindication that is listed. Alright? Okay, moving forward. Now, when you're assessing your clients, page 489. Bubble E. Bubble E, okay? You are assessing B for breast, your uterus, your bladder, bowels, which is not listed here, but make sure you know all your bubbles, your lochia, the 3 E's, episiotomy or the epidural site, as your book mentioned. You're also assessing the extremities because you don't want to see, for example, any swelling. Both the lower extremities especially should be the same size. One side should not be bigger than the other, for example. And the third E is the emotional status, like we said, because again, that is a sign that if they are going through postpartum depression, that's a safety concern. Okay? Now, know the risk factors for infection, for example, would include C-section or assisted delivery like a forceps or the vacuum, diabetes, long labor, especially over 24 hours, like your book mentioned. Multiple vaginal exams could be another risk factor for infection, prolonged rupture of membranes, which we'll talk about more in depth later on, especially over 24 hours. Indwelling catheter, this is why we try to avoid them because of the risk of infection. Manual placental removal, instead of the placenta coming out on its own, they had to manually get it out. That's also a risk for infection. Anemia or generally just a weak immune system. Those are some of the risk factors. Make sure you know some of the risk factors associated with postpartum hemorrhage. For example, they have a high risk factor if they had a very fast labor, like Chella was mentioning earlier, less than 3 hours, uterine atony, like we talked about, placenta previa or abruptio. Again, we'll talk about those. We didn't talk about the placentas yet, did we? No. Okay, we'll talk about that later on. Labor induction, operative delivery, of course, a retained placenta. The placenta didn't come out like it was supposed to. Or parts of it is retained. This is why when the placenta comes out, you are doing a thorough assessment because entire placenta is not out. Then there's and if it's retained, then that could put the mom at risk for infection, sepsis. I was gonna say GIC too as well. Okay, and other issues potentially. So you got to look at the placenta. Multiple births close together. That's what I'm telling you. Don't just depend on the breastfeeding alone. So we don't want you to get pregnant too soon. Give the body some time to heal before you get pregnant again. Large babies or multiple gestations all at once could also increase the risk of infection, even obesity. So when you are looking at the breast, for example, doing your bubble E assessment, you are inspecting the size, the contour, looking at the breast for any redness, nipples, or cracks. You want to make sure you note for normal changes like the milk starting after the delivery of placenta. The breast should be feeling firmer when the milk comes in, and of course you will have that breast engorgement where it becomes harder and tender. That's normal. But you want to note or check for latching issues if the nipples are, like for example, bleeding. The nipples should not be bleeding. That baby better not have any teeth either, okay?
My little cousin was born with his bottom 2 teeth.
Really?
His mom ate like fucking 8 pieces of cheese toast every morning. I was like, you're giving that baby way too much calcium. But yeah, and they fell out eventually, but
Did they check him to make sure there was nothing abnormal, like wrong or anything?
well, I mean, he's got cystic fibrosis, but when I found out he was born with them teeth, I was like, don't breastfeed that baby.
No, for real. Okay. Now, for parents not breastfeeding, of course, you want to avoid stimulating the breast, okay, because it also produces a lot of milk. The uterus, I put it right here. What are you targeting? Again, like we said earlier, firm in midline. It should be at the umbilicus at least up to 12 hours after birth. It needs to be at the umbilical level. Afterwards, like we said earlier, it should descend 1 centimeter a day, and look at the warning signs, because we do not want a boggy uterus at all. Because boggy uterus again means what again? Hemorrhaging. So don't play with me. Alright? If it is boggy, we know that it's potential hemorrhaging. Could we do something as nurses? What can we do? We better be massaging it. Bladder, make sure again, large amounts of urine after birth is expected up to 3 liters a day. Some people do not feel the urge to void, so you want to make sure you assess them. Are they even urinating and how much they're urinating? Again, too much is not a bad thing, okay? But just note that they can go up to 3, they can excrete as much as 3 liters a day. Now, it matters, or this is important, because a full bladder can push the uterus upwards, and that could be a problem, or it could prevent contraction. And remember, we said earlier, if it's not contracting, if the uterus is not contracting, it could increase the risk of hemorrhaging or bleeding internally. So we want to make sure that they are emptying or voiding, especially within the first couple of days postpartum. Warning signs, again, unable to void within the first 6 hours, like Makeda said. Because of the risk of bleeding, we're gonna stick that. We are going to insert a Foley catheter. Okay, that's probably one of the interventions. If we tried other measures and didn't help, but we're not playing with that because of the increased risk of bleeding. Other warning signs: burning or painful urination. You should not be having that. Feeling bladder is not emptying, or round mass above the pubic bone. That's another problem. So again, we're looking at all those warning signs. We want to encourage the client to void as frequently as possible, and we are monitoring their output. Because if you're not urinating as you should be, then there's going to be other problems, okay? Continuing the other bubble E, we are assessing again like the bowels, which is constipation is a very common cause because of maybe hormonal imbalance. Maybe they were on pain medications like ibuprofen, or for example. We talked about it already, low fiber and fluid intake, etc. We are assessing the lochia, and don't forget Professor Chella on the lochia. It better go from dark red to bright. Once the discharge is light, stay light. Yeah, that's better, right? All right, stay light. If it goes back dark, then we got a problem, okay? That's a danger sign that becomes your priority patient. Remember, your patient who went from dark red all the way to light like they're supposed to, and they went back dark, we're not playing with this patient. They are probably what? What's going on with them if they go back dark? They're probably bleeding, okay? And again, we should not, now, a normal smell, fishy smell is okay. But if it's like, very mild odorous, is very foul, we might have a problem, all right? So, might indicate, for example, endometritis, like we said earlier, all right? Then, of course, we're assessing the other E, for perineum and extremities. Check for edema, like I said, for bruising, hematoma. This is where you get the Vita. Excuse me. What else? You are checking for redness, for swelling, bruising, hematoma. Again, looking for signs of infection. You want to make sure it's mild swelling, bruising is okay. It's when it's like excessive swelling, then we have a problem, okay? Just note that it is normal for healing to take place, especially with regards to the perineum, about 2 weeks. It becomes dangerous or a danger sign or very concerning when they have severe pain. like the hematoma, they have that bluish swelling in the perineal area. Redness with discharge, that's a problem. White streak along the incision side, or incisional pain, or increasing pain, okay? Like it started off mild and then now the pain is getting worse and worse. That is also a problem. That has to be reported immediately because interventions have to be taken as soon as possible. Sometimes putting ice pack or maybe a sitz bath may help, but we are not delaying care with regards to that. We also want to make sure we pay attention to the epidural site. If they did have an epidural in place, check the site for redness. Look at if there's any drainage. There should not be any drainage at the epidural site. Look for any signs of infection. You guys should remember the signs of infection, such as redness, etc. Note any side effects like itching at the epidural site, or sometimes it may be beyond the epidural site, the itching, nausea, or urinary retention. So you want to make sure, again, note and document the intake and the output. It is very, very important. Some physicians are very strict about the output too. What's going in and what's coming out is very important because that can also be indicative that something physiologically is not correct, okay? When you're looking at the extremities, like we said, look at that calf. If there's any pain at the calf area, you are definitely concerned. If there's any swelling, redness, warmth, that or even shortness of breath, they may have pulmonary embolism. So that's an emergency, okay? Note the risk factors associated with that. Again, we talked about some of them: obesity, smoking, C-section, multiple births, hypertension, or past medical history of having clots in the past can also increase the risk of a clot, okay? So again, we want to get the mom up and moving as safe and feasibly possible, and they need to be educated on what those signs and symptoms are so that they know to report as well, okay? So again, making sure in all we note the do a postpartum assessment, which includes noting proper uterine contraction, any signs of bleeding, infection, the bowel functioning, healing, blood clots, all of that. We want to make sure we recognize any signs of hemorrhaging DVT so we can intervene appropriately, all right? Then you have the psychosocial dynamics, bonding versus attachment. We basically talked about this already. Same thing again. We want to make sure we assess and focus on emotional status, bonding, and how attached they are. The parent and the baby are bonding. Both parents, if both are involved. Is there any interactions with the family, etc. So just make sure you note those because we talked about the attachment and stuff like that. Again, make sure we encourage that skin to skin or kangaroo care. If they choose to breastfeed, that's fine. Whatever method the mom or the birthing parent chooses to feed their child, there's no wrong way. It's either you breastfeed or you feed with formula, okay? We talked about cultural competent care, same thing, ain't nothing new, all right? Same enchilada. I'll just go back on chapter 15, it's the same thing repeated again, all right? And then we also want to make sure we assess for the bonding. I said this already, same thing. Again, we want to make sure we know the positive versus the negative indicators that there is a bonding taking place. They're adapting if there's direct eye contact. They call the baby by a special name or whatever, etc. We know it's not adaptive or negative indicators indicate that there's apathy. They avoid even having interaction with the child. They are inconsolable. There's poor feeding, etc. So those are the signs. And of course, unlike Stephanie, who's going to be with the baby and the family until they're 24 years again, we will prepare for discharge, okay? We will prepare for discharge, again, teaching according to their needs. Perineal care, comfort care, ice pack within the first 24 hours if needed, if it's not contraindicated, or sitz back. Now, I know the book says heat and ice is okay, but you got to follow facility protocol. There are facilities that you can't even do the heat and without a prescription. You got to get a doctor's order because of the risk of burning the skin. All right. So for the book purposes, we just gonna say it's okay, but just know when you get to the actual unit, and this is regardless of whatever unit, whether it be mother baby or med surg or ICU, there are facilities you have to get a doctor's order to even apply. Okay? And of course we're gonna try to promote, if there's uterine anatomy or whatnot, or get that Kegel exercise up and going, okay? Boom. Now, in the book, page 513, with regards to preparing for discharge, in the ebook it's probably 512. You see that preparation for discharge? Note the bullets. The one, I said most of them already. Page 513 in the actual book, the bullets. In terms of preparing for discharge, you need to make sure you know the blood type, okay? So you want to make sure discharge should not happen too early, of course. Discharge does include, criteria are also met. In addition to assessing, making sure that the uterus is firm, etc., noting the output, the blood groups, ABO blood groups and RHD statuses should be known. And if indicated, we need to make sure we give the RhoGAM. How long after birth should we be giving RhoGAM?
72 hours.
You have up to 72. The sooner the better.
But up to 72.
Up to 72 hours after birth. And during pregnancy,
28 weeks. Yeah.
don't play with me. Aubrey, as the great fantabulous L&D nurse that you, mother baby nurse that you are, you can't prepare for delivery. Your mom is RH positive and baby is RH negative. You said, let me go hook my mama up with that RhoGAM, correct?
No, this is the opposite.
Okay, just making sure. Just making look, Rebecca was about
No, I'm scratching.
Oh, you are? Okay.
Not saying that.
You see that? You saw what I did there? Don't play with me.
So the only way like I remember it is mom is pregnant, she's getting rid of the baby, so she's negative and the baby's coming into the world, which is adding to the world, so the baby would be positive.
Ooh,
That's what
I
I
heard that. Nah, say that loud so TikTok say here.
So
That's good.
Mom is pregnant, but when she's getting rid of the baby, she's RH negative. The baby's coming into the world, adding to the world, so the baby would be positive. That's when you give RhoGAM.
I like that.
Can I get a sticker? I ain't got no stickers on my computer, but I need a sticker.
Oh, what's the sticker thinking for jigger? No, that was a good one. I like that. Now, again, in addition to everything I said, you got to make sure you do the screening. Like I said, the blood type, the RhoGAM and stuff like that. Of course, there is follow-up care, making sure you do. Follow-up care can include phone calls, maybe office visits, home visits, whatever, okay? Just make sure you know some potential challenges that may be faced during discharge, which can include like lack of support, isolation, fatigue. They may feel overwhelmed because just like how y'all in nursing school, y'all feel like y'all got too much information to learn. They are overwhelmed with a lot of information as well. This is a new thing for them. Okay. So just make sure within the first week as nurses, it is our responsibility to check on how they're feeding, make sure they're not bleeding, what their pain levels are, what their emotional state is as well. So we try to keep them as stable as possible. Now, when it comes to breastfeeding on page 505, I believe, now they talk about how to help support breastfeeding as well. So assisting with breastfeeding versus bottle feeding, they have lots of questions as new parents, especially if they're new parents. We want to make sure we address those questions. Madison, breastfeeding or bottle feeding, which one is better than the other? What says thou?
A fed baby is the best.
A fed baby is the best baby. So what you trying to say?
Whatever the mom prefers.
Whatever the mom
I just said
prefers.
it's not black and white. Like, is it really a black and white?
No, in other words, one is not better than the other. One is not better than the other. She said, you said breastfed baby?
A fed baby.
A fed baby. As long as the baby is fed, whether you choose to feed via breast or formula. That's what I said, right? Formula?
No, you said bottle. That's why I said it's the
Oh,
same thing. So
okay, formula. I keep doing that every single time. I'm sorry. That's
Put breast
Wait,
milk in bottles.
okay. I'm not trying to be that person, but then in that case, then what I was trying to explain then, yes, if the baby's fed, then the baby's fed.
the baby.
But the most benefits would you say is breastfeeding? That's kind of what
It
it's
depends. You know why? It does not want, even according to the research or book, because it depends on the needs. Both will supply the needs for the child in some way, shape, or form. Like Maddie was saying about the irons and the nutrients, etc. The formula will still provide the nutrients for that child. Now, does one have benefits that the other does not have? Yes. For example, you mentioned like that skin to skin contact. You may feel it more, of course, with the breastfeeding, but it's not that you won't feel the skin to skin. Is it impossible to feel to have that skin to skin contact with a formula fed baby? Yeah, you just go. Maybe you be shirtless or topless or some sort, and you still provide that skin to skin. You understand? So. Why say one is not better than the other? Because as we'll learn later on, certain populations cannot breastfeed.
Yes, and I know that too. That's why I was kind of like.
Yes, that's why one is not better than the other.
Yeah.
Okay. Alright, but like I said, exclusive breastfeeding is encouraged for the first 6 months, but can continue for at least 1 year or longer, like we said earlier. We already said the other ones now. Hospitals should have a breastfeeding policy. It actually says in the book. Okay. Staff should be trained properly on how to properly educate. So for lactation purposes, if they're going to do breastfeeding, or educate on how the frequency of feeding, whether it be formula-fed baby versus breastfed baby. Educating families, etc. Encourage feedings on demand. Okay, so whenever the baby need it, go ahead. All right. Ask for, if they do want to do breastfeeding, they can offer tips. Now, the only thing is, with regards to the teaching steps, before feeding, we are encouraging the mom to make sure she knows to wash her hands and be in a comfortable and relaxed position, because if they're not comfortable and they're not relaxed, then that can pose a challenge to an adequate feeding. Okay. Now, you do want to feed when the baby shows signs of hunger, but expect stronger after pains during breastfeeding. Okay, the after pains that we talked about earlier. During feedings, you want to make sure, as you see like here, you hold the breast like in a C shape. Tickle the baby's lip to open their mouth wide. Bring the baby quickly to the breast, and also listen for the swallowing. And if you need to break the suction, gently do so with the finger when removing. Now, after feeding, we do want to burp the baby. Anybody not know how to burp the baby? Oh, so everybody know how to burp the baby. Tim? Huh?
Not just after, you need to do it during the feeding. You need to stop them.
Give them a few.
Yeah, you need to stop them and burp them a little bit.
Okay, talk to me a little bit about that, because I don't know. You said during the feeding, so while they're on the breast or while they're being fed, I gotta stop them?
Yeah, sometimes you have to help get the gas out.
Yeah, they spit up a lot.
And then, yeah.
Okay.
And then it'll encourage them to eat a better amount, instead of just like being filled up with that air, that gas bubble, and then they start throwing up, and then they lose all the nutrients that they just had because you didn't burp them.
Okay. Feed them all over again. Okay. Very good. I like it. I take it. Now, also, want to encourage to switch the breast. We should not, if they're breastfeeding, they should not be breastfeeding on one, for multiple times straight. For example, if you breastfed on the right, next feeding, we breastfeeding on the opposite. Okay, breast. Okay. And of course, we want to, be their biggest cheerleaders. You want to praise them, reassure them, hey, you're doing a good job. so on and so forth. Alright, you wanna encourage frequency on either on demand, usually typically every 2 to 3 hours, and of course, that skin to skin contact is usually what helps expedite that and encourage feeding. Lactation management. What's a contraindication to breastfeeding? HIV, what were you saying, Michaela?
Well, I said HIV, but also like drug use.
Drug, okay. I'm gonna come back to that drug one right there.
Okay.
When they're sick, when like mom is sick, and then I answered saying, no, you can do that because it gives the baby.
Say it again.
It gives the baby the immunity.
Okay, so it depends on the sickness, right? Certain sickness, like especially if you like have like what you mentioned, HIV, because you can't be sick, you definitely, well, you shouldn't be breastfeeding at all. Okay. Yes.
I thought you can breastfeed with HIV, but if your viral load is over 1,000.
Okay. Okay. Let's go to that page. You might be right. You might be wrong. Yo no sé. No me sabo. We gonna validate that because Michaela said if everybody on drugs, I mean if the person not everybody on drugs, although if you on any drug, you should not be breastfeeding. Let's go to page 505. Notice what it says. Certain people should not be breastfeeding, including those who are taking illicit drugs such as opioids, cocaine, etc., etc. In the parentheses, note what it says. Note that people who are stable on methadone treatment may breastfeed. Yes.
I got a question. My mom this week was on Subutex, and they told her that she could not breastfeed, and that she was doing, well, she apparently was doing, what's it called, formula feeding, but the baby weighed less than when it was born 2 months later, so.
You're not talking about your mom.
No, no, Because
I was gonna say,
Yeah.
wait a minute, what? That's a huge gap. Like,
I made a
yeah, that's why I was looking at you like,
We looked at each other like,
yeah. Okay.
I'm sorry.
She's on what drug? I never heard Subutex, you said?
Subutex, it's like kind of like for methadone, but she was a crack cocaine user.
That's probably, but now.
is it Subutex or Suboxone?
No, it wasn't Suboxone because I said it's Suboxone and they said
Yeah.
it's Subutex.
Oh.
And apparently that's also addictive to
Yeah,
babies as
Suboxone is
well.
what they give heroin addicts to detox.
She was on, I guess she's on a lot of stuff, but her choice was crack cocaine.
Then,
I don't know, but
I don't know. I don't know that. For
That's
facility,
what I asked.
yeah, I'm not sure about that one. I can't even answer that one. That's interesting. But just for test purposes, just know that if they are stable, now if they are not stable on the methadone treatment, like they're still going back and forth and doing what they shouldn't be doing, of course, they are not a candidate for breastfeeding. Alright, just like everybody, any other drug user. Okay, yes, Zelda.
The HIV.
The next one, it says with HIV infection who are not on antiretroviral therapy and achieving viral suppression, they are at increased risk of transmitting. So that answers your question.
But what?
Oh, I don't know the number. I am not going to even lie to you. I don't know the number. It's not a question. It's not. Okay. You know what? I should make that a homework. Look, you hear the size? My gosh, okay, keep it moving, but no, I don't know the number. That's all I'm gonna ask you on your test question anyway. Okay? Who else? Other contraindications, again, the illicit drugs, galactosemia for the infant, active HSV, lesions on the breast. If you have HSV, if the mom has HSV, can they still breastfeed?
Yes, but not with active lesions.
Yes, okay, so pay attention again to the drama, okay? If they have active lesions on the breast, then they cannot. But if they just have simply been diagnosed with HSV, then they still
It's
can.
like
That's
when
what-
giving birth, they'll do a C-section if the mom has an active lesion.
Yep.
But if she doesn't, they'll let her do that.
The other thing too, if they do have the HSV lesion, like on one breast only, but on the opposite breast is clear, they can breastfeed on the other breast that has no lesions. Does that make sense? According to the book. Certain infections like monkeypox, brucella, TB, like we said earlier. Those are the type of illnesses. Make sure you pay attention to that little note, the teaching guidelines for breastfeeding on page 506. Then on page 507, while I see, just make sure you pay attention to the special consideration, a higher BMI. Parents with obesity may have delayed milk production. They may have difficulty with latching and lower prolactin response. And they may end up stop breastfeeding earlier than desired, okay? So obesity does also increase the risk of childhood obesity, all right? And breastfeeding rates are lowest amongst African American women, so we gotta educate them more, apparently, all right? What else do I want you to know? You wanna make sure you assess the breast after birth, and we already talked about this. Make sure you assess, you're looking at the fullness, so that milk is coming in. Look at the condition of the nipple. Make sure you assess for signs that breastfeeding is working well, that there's no pain. The breast should be soft. Feeling that tells you that the milk is coming in. But if they're engorged, that means it could be very hard and swollen, so that's very painful for them. And even if the parent, again, is not breastfeeding, like I said, they should still check the breast for engorgement, redness, and signs of infection. Even if they are not breastfeeding, you still want to check for those things, all right? Engorgement should resolve on its own. Usually it improves within 3 days or 72 hours, but it should be self-resolving usually. And I already told y'all what to do for the engorgement already. Bowel feeding or formula feeding, to be specific, all right? It is the parent's choice. It's not a bad thing if they do decide to formula feed instead of breastfeeding. You just want to make sure you know the different types of formula, and the different types of formula, as indicated on page 507, includes commercial formulas like cow's milk, soy-based milk, or specialized formulas depending on the baby's need, like if they have any allergies or any medical conditions. Just know that it comes in different forms, like powder, where you gotta mix it with water, concentrated, ready to use, or prepackaged. Now, times could be hard. Like right now, gas prices is shooting up. You know, eggs is almost the price of, I don't know, still high. But you still gotta encourage the mom not to over dilute the milk, okay? So make it stretch. Okay, because if they do that, what can potentially happen? Huh? They could be malnourished. They're not going to get what they need. Okay, so don't stretch it. Now, what else? You do need to know the nutrients that your baby does need. Newborns need about 110 to 135 calories per day, per kilogram, and formula provides 20 calories per ounce. Okay, so that means most newborn need about 2 to 4 ounces of calorie per feeding, and that's about 6 feedings per day that they would need to about 4 months. All right. Now, after 4 months of age, typically, depending on the need, give or take, feeding should decrease, and then this is when you're going to encourage bringing in solid foods slowly. Okay, you want to do it slowly so you can see how the infant tolerates that new introduction of the solid food. If they tolerate it well, then we can continue it, and then you start slowly reintroducing other solid foods. Okay. What else? When preparing the formula, again, wash your hands with hot soapy water. Make sure the bottles and nipples are clean. When preparing formula, it should be at room temperature water for the powdered formula, and you refrigerate the prepared formula. Never microwave formula. Never, ever microwave formula, no matter how tempting. If we need to warm it because it was in the refrigerator for like 20 minutes or whatnot, or 30 minutes, what do?
Warm water.
Use warm water, okay? Again, do not dilute the formula to save money, because again, that puts them at risk for water intoxication. But if you're going to save the formula because the baby was full or whatnot, or for whatever reason, any unused formula should be discarded after an hour. So prepare accordingly so you don't waste the formula, alright? Again, during feeding, always hold the baby. Never prop the bottle. You don't want to prop the bottle. Don't be extra with it. Hold the baby semi-upright to prevent choking. They definitely should not be lying flat. Tilt the bottle so the nipple stays full. Because again, like it was mentioned earlier, if the nipple of the bottle is not full, then they could inhale air, and we don't want that. All right. Burp frequently, and of course, place the baby back to sleep. Y'all should already know this is from first semester. What you are not going to do to safely feed this baby, you're not going to add cereal to the bottle. You're not going to put the baby to the bed with a bottle because of the risk of tooth decay, okay? And it's not safe. Do not save the leftover formula. Do not force feed the baby, and do not add anything extra to increase fullness. Again, because that can cause GI issues, okay? Bonding, of course, you could promote bonding during bottle feeding by smiling, talking softly, making eye contact, etc. But the basic thing you need to know is how to maintain safety while feeding the child, whether it be breast or bottle feed, or formula feed, I should say. You want to make sure the baby's in the correct position, and of course, make sure you maintain proper storage. Again, after an hour, anything left unused is discarded. Resuming a safe life, we already talked about this, I don't need to go into that. That's the same thing from chapter 15. Maternal malnutritional blueprints, again, if you make sure you know the amount of nutrients that the mom should be consuming during the day, like 1,000 milligrams of calcium per day. I didn't do that nutrition benchmark. I did the open one, right? Yeah, so just in case, it comes up. All right, and then of course, make sure you encourage nutrient-dense food, so both mom and baby, especially mom, gets the proper nutrient, especially if she decides to breastfeed, so that the baby can also get the proper nutrients as well. You are telling mom this is not the time to do any kind of diet. We ain't trying to look like Kim Kardashian up in here, all right? No diets, no fad diets. You're trying to make sure you stay healthy, eat healthy. Especially to properly nourish yourself and the baby, the newborn, and you cannot pour from an empty cup. So take care of yourself, in other words, all right? And then of course you want to make sure you address how the family is adjusting. If there's any siblings, include the siblings so that they don't feel left out or jealous or anything like that. So encourage them in the care of the baby as well, as safely as possible as well, okay? So you support, make sure you address any conflicts, especially now, of course, when the grandparents are involved, they might have, especially depending on the culture, they might want things done this way. So we might want to encourage, parents to just be the grandparents to be a support, okay? And show them how to be a proper support for the child, not to add to their stress, okay? Because it can happen. So again, you want to make sure you do the proper assessment. This is basically a summary of everything. Doing the proper assessment, making sure you're noting and assessing and noting for any signs of danger, that we address it as soon as possible. I noted some of them. Make sure you provide the proper support, and of course, you want to empower by providing the proper education. All righty.